All right, welcome everyone to our presentation today, the first session of our series on how to prevent pesticide poisoning in farm workers. Today's presentation will be on diagnosis and management of pesticide-related illness. My name is Marta Alvarado. I am the manager of online education for MCN. I'd also like to acknowledge our partners for this series, the University of Illinois, Chicago, and our presenter, Dr. Brett Shannon, who will be introduced in just a bit. Another quick reminder that if you have questions at any time during the session, please enter them in the chat or Q&A, and they will be answered at the conclusion of Dr. Shannon's presentation. Next slide. A reminder that this session is being simultaneously interpreted into Spanish. If you want to listen to this presentation in Spanish, at the bottom of your screen in the Zoom toolbar, there is a globe-shaped icon. Click on that icon and select Spanish from the menu. If you are joining from a cell phone, locate the three dots that say More, select Language Interpretation, and select Spanish. Next slide. Likewise, if you would like to view the Spanish PowerPoint presentation, at the top of your screen, there is a tab labeled View Options. Click on that tab. A drop-down menu will appear where you can select the deck in Español. If you're on a cell phone, touch your screen and the options menu will appear. Click on the three dots that say More, select Language Interpretation, select Español, touch Done. Next slide. This presentation has been accredited for one hour of continuing education by both the American Nurses Credentialing Center's Commission on Accreditation and the American Academy of Family Physicians. Requirements to receive credits are seen at the bottom of the slide. Next slide. To be compliant with the accrediting agency's policies, I'm going to go ahead and read the disclosure statement. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. This presentation was supported by an independent medical education grant at the University of Illinois, Chicago. No relevant financial relationships were identified for any individuals with the ability to control content of this activity. Next slide. Finally, we'd like to acknowledge that the University of Illinois, Chicago sits on land that was once home to 3 North American Native tribes, a partnership that goes back centuries. We just want to acknowledge that here. And with that, I'm going to go ahead and let my colleague Amy Lee take it away. Go for it, Amy. Amy, you're on mute.
Okay, sorry about that. It's with great pleasure for me to introduce our colleague, Dr. Brett Shannon. He is an occupational and environmental medicine specialist from Australia, and he has undertaken occupational and environmental medicine work with clients in the agricultural, construction, mining, and aviation industries. In his practice, he has evaluated patients occupationally exposed to pesticides and teaches about the recognition and management of pesticide poisonings. In 2021, he was a recipient of a John Monash Foundation Scholarship and has just completed a PhD in Environmental Occupational Health Sciences at the University of Illinois, Chicago School of Public Health. Dr. Shannon has been involved in the governance of minority health clinics in Australia for over a decade, and he is the past chair of the Brisbane Aboriginal and Torres Strait Islander Community Health Service and has served as their director for 9 years. With that, I'm going to turn it over to you, Dr. Brett, and put your questions in the chat, and we'll have a nice Q&A at the end.
Thank you, Amy, and thanks everyone for joining today. I'm really excited to talk about this topic. I think it's a really, really important topic. So we've got a lot to go through in an hour, so I'm just going to dive right into it if that's okay. Next slide, please. Before we begin in the body of the talk today, I just wanted to share a few cases to show why this is still an important topic in our community. This is a case you might have heard of from the summer of 2019. There are actually 27 farm workers involved in this case that got sprayed overhead while working in a cornfield in central Illinois. they were clearly visible at the time of spraying. They were wearing high visibility clothing. And then 2 weeks later, unfortunately, they were actually sprayed again. And at that time, 2 weeks later, they were sprayed twice within 30 minutes of one another. These workers were 2HA workers, and they involved teenagers, older workers over the age of 60, and actually a pregnant woman as well. So there was understandably a lot of concern about these cases from the community, and acute management appears to have been quite poor. And I believe the litigation process is still ongoing for this case at the moment. Next slide, please. The next case I wanted to quickly share with you is a case that involves a different kind of pesticide that we'll discuss today called pyrethrins or pyrethroids. And this case is a bit different because pyrethroids, lots of common household products have pyrethrins in them. Currently, there's about 2,000 registered pesticide products in the United States with pyrethrins in them. And this accidental exposure in this case here involved a child who was exposed to pyrethrins in the house when their grandmother, who's illiterate, was spraying pyrethroids downstairs close to the baby's bed. And unfortunately, within 20 minutes, this child went into respiratory distress, thankfully sought some medical care immediately and was treated therapeutically and standardized in the hospital. But this case I wanted to present because despite some pesticides being used regularly in the home, even weekly or daily in some situations, and we think that these pesticides are safe, they can actually cause issues in particularly those in our community that are vulnerable, such as children, pregnant women, and the elderly. So I think this case highlights any pesticide we need to be concerned and think about those vulnerable in our community. Next slide, please. One of the other pesticides I wanted to talk to you about today is rodenticides. So this is a really tragic case, unfortunately, in Texas, where rodenticides caused 4 deaths in a house. Rodenticides come in lots of different forms and different toxic levels. Anticoagulant forms are the most commonly used. And here, a family in Texas were actually using a rodenticide called aluminium phosphide. So it comes in pellet forms, and they put the pellets under the house because of a mice problem. And unfortunately, one of the members of the household wanted to get rid of the pellets afterwards and sprayed them with a hose, which released phosphine gas. And this is a highly poisonous gas. And unfortunately, it caused the members of the household, their lungs to fill with fluid, and 4 of them to die. So it's a really tragic case. And really, again, kind of I wanted to highlight with these cases, they're all very different. One with overhead spraying, one with spraying indoors, and one with rodent pellets releasing gas, but they all had significant consequences, and it shows the array of circumstances you can be exposed to pesticides. Next slide, please. With that being said, and introducing those cases, just to share our learning objectives for today. So we have 3. The first being, we're going to talk about 3 different classes of pesticides, particularly those classes that I just discussed in those cases. We're going to talk about exposure scenarios and clinical effects. Then we're going to talk about how you manage or triage pesticide-related illness cases. Then we're going to discuss what is known about the chronic effects of lower level exposures to pesticides as well. So that's our 3 learning objectives for today. Next slide, please. So I said I'm really passionate about this topic, and I really love that we focus on pesticides. And why is that? Because I think this is still a big issue in our community that doesn't get the attention it deserves. Despite improvements in recent decades in safety practices, as well as regulations for some pesticides, such as organochlorines, it's still a big problem in our community. You can see from this national poison data here from the United States, about halfway down, you see pesticides there, but out of single substance exposures that report to poison centers, pesticides is still a common exposure we're seeing. And this includes sort of work exposures as well as non-work exposures. Unfortunately, we have a lot of unintentional and intentional use of pesticides as well. So we see pesticide use in self-harm and intentional poisoning cases as well. So we see pesticides, we really need to consider those factors as well, whether it was intentional or unintentional use, whether it was work-related or non-work-related, but it's still a significant issue in our community. Next slide, please. So here I just wanted to share a bit of data on the work-related pesticide illness cases from Illinois, where I'm currently situated. So these cases, I wanted to show the occupational cases, what actual pesticide are they using or what are we seeing? And you can really see that it's a mix of cases we're actually seeing in clinical cases of pesticide-related illness. If you look at the bottom of this graph, herbicides and insecticides are the two most common groups of pesticides we're seeing, but you can see there's a big proportion that actually don't know what the pesticide exposure was. And these can be cases that were just incidentally exposed to a pesticide. They weren't actually using it themselves, or in many cases, they're using something that they don't actually know what it is. Next slide, please. And this kind of brings me to the next slide where we talk about how do we actually classify pesticides and how do we actually define them? And if you want a clear basic definition, I just put it on this slide that a pesticide is any substance or mixture of substances intended to prevent, destroy, repel, or mitigate any pest. If you look at textbooks, you might see pesticides broken down into insecticides, herbicides, rodenticides, etc. So they're kind of basing them on what they're used for. The difficulty with this classification is that there's a lot of overlap in that a lot of pesticides will use as insecticides as well as herbicides and etc. So this can be a difficult classification system. Next slide, please. So today we're not going to go through via that classification system, but we're going to talk about 3 different types of pesticides. We're going to talk about organophosphates, pyrethrins, and rodenticides. Organophosphates, many of you may have heard of. They do get a lot of media exposure and a lot of clinical discussion around them. They've actually been around since the 1850s. They're originally used to treat glaucoma, believe it or not. And since then, they've been used in the development of nerve gases in the military. And then they've been used in farming and household pesticide products since then as well. We've actually seen them phased out of a lot of household pesticide products, but they're still very commonly used in agriculture, particularly in fruit and vegetable pest control in the United States. For those that want to know how chemically organophosphates work, they're actually produced by the reaction of an alcohol and a phosphoric acid group, and they work by paralyzing muscles essentially. And in large amounts, they can kill bugs and pests, and they can also harm humans and paralyze humans as well. And we're going to discuss how that works in this talk today. Pyrethrins are that class that I just showed you the case with the child at the start of this talk. So pyrethrins are actually pesticides that are found naturally in some flowers called chrysanthemum flowers. They're these bright, colorful flowers. And those natural pyrethrins have since been used to develop synthetic pyrethroids. And typically these drugs or these pesticides are used to control things like lice, mosquitoes, cockroaches, beetles, and flies. And in some horticultural crops, we commonly see pyrethrin dusts used to control all those sort of insects in these crops. And we're going to talk about pyrethrins today, and they're a very interesting group, and I don't think they get enough attention. And the last group we're going to talk about today is rodenticides. So rodenticides is actually a big group. There's a variety of compounds that come under rodenticides, and they all differ in their chemical composition, their mechanism of action, and how toxic they are. So we're going to discuss some of the older rodenticides. So this is things like arsenic, phosphorus, thallium. And then there are there are the big class, which are the anticoagulant group. This is the warfarins and the superwarfarins. And a lot of people are familiar with the anticoagulants. We're going to talk a bit about them. And then there's other things that come under rodenticides, such as cholecalciferol, which is actually just vitamin D3. So many of you know vitamin D3. We use it as a dietary supplement, but it's actually a very well-used rodenticide. And it's actually gets a lot of literature because we use it for a lot of residential pest control. And unfortunately, a lot of pets, cats and dogs will eat it. And it can cause serious problems then as well. So they're the 3 classes we're going to talk about today. and I'll dive right into it. If you go next slide, please. So I wanted to start with, we talked about those different classes. What are some common exposure scenarios in the workplace? And there's many different workers that are commonly exposed to these sort of pesticides. If you take the picture on the top left-hand side of this slide, think about agricultural workers can be exposed in a variety of ways. They can come into contact with pesticide residues. They can inhale pesticide dusts, and they can also accidentally ingest pesticides depending on what PPE they're using. And they can also get pesticides in the eyes. If you take the picture to the right of that, the sprayers, sprayers are another class that can be exposed in that many ways as well. And they commonly handle pesticide supplies as well. And then we have workers that work indoors, such as commercial workers and workers in greenhouses. And this group we see in the clinic as well, because they're typically in small enclosed spaces, and those spaces can have poor ventilation. Next group we commonly see is landscapers. So we see landscapers in the clinic because they're often disturbing the environment, and this can produce dust. They can be exposed to pesticide residues as well that they come into contact with. And then the last group we commonly see is storage and maintenance workers. And typically we see these workers because they're exposed to a lot of supplies, and they're typically using pesticides as well. So the point I wanted to make with this slide is that the important consideration is there's a number of common exposure scenarios, and it's going to depend on what work the worker's doing, what PPE they're using. If you talk to workers, there's certain questions you can ask. I hear from workers commonly when sprays get clogged, they'll open it with their mouth or their hands, which will expose them. And it really depends on sort of what PPE they're using, what kind of wind conditions they're around. They might be spraying against the wind and it might just come straight back into them, and what work they're doing. So you really have to take a detailed occupational history. I'll give you one example of a group here. There was a paper published in China on cotton farmers, and they found that 25% of the cotton farmers had facial numbness or paralysis. And they looked into it, and this is because they were using pyrethroid dusts on the cotton farms. And that makes sense because of what the PPE was they were using, the pesticide they were using, and the exposure scenario. So once you start knowing a bit about those, you can start connecting what symptoms you might see in these workers as well. Next slide, please. In saying that about what symptoms you might see in different exposure scenarios, I just wanted to highlight some of the common occupational routes of exposure we see in Illinois. So this data is a bit older. It's from 2016, 2017, but you can see the most common route of exposure in work cases with dermal exposure. This was followed by inhalation, and then ocular in the eyes, and then ingestion. So it's really nice to think about those 4 routes of exposure that are very common and ask different questions to see if workers might be exposed in those different routes. Next slide, please. And although we talked a lot about route of exposure and different exposure scenarios, it's not the only thing we need to think about when considering how toxic the pesticide exposure is in a worker. We need to ask about the dose, so what the concentration of the pesticide is, what the quantity, how frequent it's being used. And then once we know what pesticide it is, we can start considering the distribution, the metabolism, and the elimination of that drug. But the thing I wanted to highlight on this slide is that pesticides are really important because we need to take the individual into account. Like I said about the pregnant woman at the start of the talk and the children, there's individual sensitivities that are really important here. We need to understand what the age is of the worker, their gender, if they could possibly be pregnant, what medical conditions they have. There's different genetic susceptibilities to certain pesticides. And then we also need to consider what concurrent exposures they might have in the workplace and outside of the workplace as well. Because they might be using pesticides in the workplace, but they might be using pesticides at home as well. So there's different individual sensitivities that we need to take into consideration. Next slide, please. Now we're going to start looking at the clinical picture of these pesticides. So again, I'm using Illinois data. from 2016, 2017, but I just want to use it as an example for you on the different clinical pictures we're seeing in patients. And why I want to use this is because I want to show you that workers exposed to pesticides, they typically present with very vague symptoms, very systemic symptoms as well. So you might get workers who just present with a bit of nausea and vomiting or gastrointestinal symptoms, or you might get workers with respiratory symptoms. The most common we saw were dermatological, so skin, no symptoms, or neurological. But as a clinician, I think it's really important to put this data up there, because I think this is why we miss a lot of cases, is because sometimes the clinical picture is not so clear that a worker is being exposed to pesticides. And I just want you to know that if a worker presents with very vague symptoms or very generalized symptoms, it's really important to ask about exposure to pesticides as part of your clinical history, and consider it as a potential exposure because of the sort of symptoms we're seeing. Next slide, please. So that was sort of the overlay of the talk. Now I just want to go into a bit of the mechanism of how some of these pesticides work and some of the symptoms they produce. And this slide, we're going to start with organophosphates. So this is just about organophosphates, and this slide might look a bit scary. It might look like a lot of information, so we're going to make it very basic. This picture on the right hand of the slide, we're going to focus on it. And this is a nerve cell. So the big yellow thing is just a nerve cell. And all I want to say is when a signal reaches a nerve cell, it releases something called a neurotransmitter. And this carries the nerve cell to the adjacent nerves or to other organs such as muscles or glands. So the neurotransmitter you can see in this picture is those blue dots there. Once that neurotransmitter passes to the next nerve, typically we have this enzyme called acetylcholinesterase. So in this case, we're talking about acetylcholine is the neurotransmitter passing to the next nerve. And then we have this enzyme called acetylcholinesterase, and it kind of cleans up the acetylcholine and gets rid of it out of the junction there. And unfortunately, what happens with organophosphates is they block this enzyme. So they block that acetylcholinesterase, which is there in the junction. What this means is that all that acetylcholine there in the junction between the nerve cells doesn't get broken down, and it just stays there. So what does this mean? So then this acetylcholine can act for an excessively long time, which can cause symptoms like twitching or increased secretions. And then eventually the nerve cell will just get tired and will just essentially cause paralysis of the muscle or whatever it's connecting to, because it'll burn out. So that's kind of a very simplified way of thinking about organophosphates. And all I want you to remember from this slide is that organophosphates block acetylcholinesterase, which is the enzyme that breaks down acetylcholine. That's the main point of this slide. Next slide, please. Because now that we've talked about that, we can start thinking about what the acute effects are of organophosphate poisoning. And the easy way I think of this is because we have that buildup of acetylcholine, everything is just firing too much. So that makes it easy in your brain to think about what you're going to see. So diaphoresis is excessive sweating. You're going to get excessive salivation. You're going to get excessive tearing or lacrimation, excessive urination, excessive defecation, gastric emptying, and meiosis is this constriction of the pupils, which is the picture on the right-hand part of this slide. An easy way for people to remember this, some people like to use the acronym MD sludge. So we put it in that order for you. I just try to remember that everything is happening excess and it kind of fits in with what's going on in the picture. But that's an easy way to remember it as well. And that's organophosphates. That's what I'm going to talk about with the mechanism of action. Next slide, please. And the next mechanism we're going to talk about is pyrethroids. So pyrethroids, like I said, these are sort of the synthetic version of pyrethrins. And today there's actually thousands of different pesticides registered as pyrethroids in the United States. Some familiar brands you might be aware of are like Raid and Off. These contain pyrethroids. And like I said, historically, these pesticides were commonly used for flea and lice and and agricultural pests, but now they're commonly used in households as well. And we actually use them as like powders, gels, sprays, aerosols, mists. So they come in a number of forms. So this slide, I just wanted to share how these pesticides actually work. And again, it's to do with our nerve cells. So this picture on this slide is on the membrane of a nerve cell. So on the membranes of nerve cells, we actually have sodium channels. And when a nerve cell is depolarizing or sodium channels open and you get an influx of sodium, and that causes depolarization of the nerve cell, which can lead to different symptoms depending on what the nerve cell is. Unfortunately, with these pyrethroids, when the membrane of the nerve cell, when the nerve cell doesn't need to fire, we close those sodium channels in a normal patient. When we have pyrethroids, they actually leave the sodium channel open. So the sodium channel stays open and you get this nervous influx and repetitive firing. And this leads to symptoms like tremors, involuntary movements, excessive salivation and secretions and things like that as well. So similar symptoms to the organophosphates, just a different mechanism. We're not talking about acetylcholine now. We're just talking about sodium channels in nerve cells staying open. An easy way to kind of remember this as well is clinicians and certain people call it the knockdown drug because it causes pests to get knocked down and paralyzed essentially because the sodium channels are left open, if that helps. But that's all I'm going to say about the mechanism of pyrethroids. Just sodium channels, the membrane of nerve cells is all you need to know. Next slide, please. So based on their chemical structure, pyrethroids are typically divided into two groups, type 1 pyrethroids and type 2. All I wanted to share with you is a different breakdown of these two types because type 2 is considered a bit more severe than type 1. So type 1 pyrethroids, like I said, they cause that repetitive discharge of the nerve. And in these cases, they're commonly referred to as T syndrome because you get these repetitive fine tremors. And you also get paresthesias. If you think about those cotton farmers I mentioned in China, how they were getting the facial paresthesias. Whereas type 2 pyrethroids, I consider a bit more severe. They have a more pronounced convulsive phase, and these ones typically are referred to as CS syndrome. So you get chorioathetosis, which is just essentially irregular muscle contractions, and then you get the excessive secretions as well. And as these drugs get more severe, you get more systemic symptoms as well, which we'll discuss in the next slide. But that's type 1 and type 2 pyrethroids. Next slide, please. So like I mentioned, there's actually a spectrum of poisoning in pyrethroids, just like any other pesticide. So in suspicious or mild cases, you will typically get like the facial sensation, the facial numbness. You might get a contact dermatitis, and then you might just get really vague symptoms from workers, such as dizziness, headaches, nausea. And then as you get more severe poisoning, you can actually get convulsions, coma, pulmonary edema, which is like what we saw in that child in the case at the start of this talk. So the symptoms become more severe and more systemic. And that's all I wanted to say about pyrethroids here. Next slide, please. The last group I wanted to discuss the mechanism of pesticides was the rodenticides. So the rodenticides have a number of categories. So we have second generation anticoagulants and first generation anticoagulants. And these pesticides work by preventing blood clotting. Animals eat these rodenticides and typically they'll have internal bleeding within a few days. All I wanted you to know about the difference between second generation and first generation is that the second generation are more toxic and persistent. They persist longer in the bodies of rodents. So they're more of a threat to humans as well. And then we have this big group called acute toxicants in rodenticides. This is made up by things like bromethalin, zinc phosphide, strychnine, thallium, a lot of these older rodenticides, some of them not really used in the United States anymore, but a lot are still used internationally. And these drugs can be very, very toxic, and typically they can kill rodents after one feeding. and they're formulated as baits typically. And the other one that I mentioned at the start of the talk that I find kind of interesting is the cholecalciferol, or vitamin D3. And like I mentioned, this is used for a lot of residential pest baits, and it can be very harmful for our pets and for vulnerable people in our community, because if your body resorbs too much calcium, it can actually impact your kidneys. I think typically pests and pets will die of kidney failure, and then you can get cardiac problems as well, obviously, if you have too much calcium. And I think you move to the next slide. So the next slide is just on the signs and symptoms of these different rodenticide categories. Oh, sorry, you can go back one slide. The acute exposure of anticoagulants, like I mentioned, just leads to uncontrolled bleeding. But what I wanted to mention is that that bleeding can be quite delayed, because obviously we have stored clotting factors. These have to run out, and then you might not have signs or symptoms for 48 hours post-ingestion of anticoagulants. And the acute toxicants, like I mentioned, these are a little different. You might see systemic symptoms depending on what the acute toxicant is. And these are really sinister rodenticides that can cause cardiac arrhythmias, shock, cardiac arrest, and many other conditions. And that's all I'll say on anticoagulants. This is a big class of rodenticides. It's very hard to discuss without going into a lot of detail about each individual rodenticide. Next slide, please. So now that we've talked about 3 different classes, organophosphates, pyrethroids, rodenticides, some common exposure scenarios, what do you need to know as community workers or as clinicians when triaging a patient or seeing a worker that asks you about pesticides? And really, when I do it, I really start talking to the worker about 4 different areas of questions. First, I want to know a lot about them. Do they have any serious health problems? Is there a possibility they may be pregnant? What symptoms have they had? Why are they asking about pesticides? Have they got localized symptoms somewhere on their body? Have they got systemic issues? Have they got any vomiting, diarrhea, dizziness, headaches, salivation, sweating, all of those systemic complaints you might get? And then I want to find out about any incidents, but I don't call them incidents because I don't want to narrow it down to things that the worker thinks are incidents. So I want to know about how they're storing, using, what their exposures are around the work site, anything I can ask about possible exposures to pesticides based on what work they're doing. And then to do that, I ask a lot of questions about their occupation, what their role is, where they work, how often they work, what they do day to day, and just ask them to run through a typical day at work for me. And then I want to know, lastly, if they've had any treatment. If they're presenting with any conditions, what treatment have they had? Who have they seen? How long has this been going on for? Have they been treating themselves with something and not seeing a clinician as well? So a thorough history is really important in these cases. Next slide, please. In terms of the acute cases, so you might get cases that you're very worried about at work. You might get a mishandling of a pesticide and a large toxic exposure in a worker. What do you do in this situation? So obviously, typically we'll seek urgent medical care in these situations. One thing that's really helpful for first responders is if you immediately take a GCS or a Glasgow Coma Scale, because this gives you an idea based on a lot of studies, if they have a normal Glasgow Coma Scale, so if their eyes are opening spontaneously, if they're oriented to time, person, and place, and if they're obeying commands, then their risk of death is much lower, less than 5%. But if they have a poor Glasgow Coma Scale, they're not responsive immediately, things like that. If they have a GCS of less than 10, this signifies that this is really concerning and this is a real high risk of death in this situation. So it's really helpful for first responders if you do a GCS immediately. Next slide, please. However, as clinicians, most of the cases we see related to pesticides are not those acute exposures where we're immediately worried, where a person is non-responsive. Most workers will have a normal GCS and they'll come to the clinic 3 or 4 weeks after exposure. And what do you do for these patients? If you're a community worker or someone working with the work site, I think it's really, really helpful if you can get access to any pesticide information you have. So if they can bring with them to the clinic any pesticide labels, any safety data sheets, if they have any records of pesticide applications from the work site, if they have any clothing that was contaminated, please don't throw it out, but bag it. All of these things are really, really useful for clinicians. Once the worker comes to the clinic, after taking a thorough history and examination, typically, or in certain instances, we'll get some blood from the worker. We may get a urine sample, and we may get other samples depending on where the exposure was and what the exposure was. Next slide, please. I didn't want to talk about pesticides without talking a bit about treatment. So starting with organophosphates. For organophosphates, I just wanted you to know that atropine is the antidote. And that's all you really need to remember from this slide. But just to give you a little bit more information about atropine. So how atropine works is, I told you that you get the excess acetylcholine in the junction between the nerve cells. Essentially, atropine competitively blocks the binding sites of the nerve cell. So it'll competitively block particularly the muscarinic receptors. So what this means is the muscarinic receptors are those that cause the excessive secretions. So we use atropine to competitively block those receptor sites, stop the acetylcholine working, and reduce the secretions. But it typically doesn't work very well for the nicotinic receptors, and these are the receptors that cause the paralysis and the fasciculations, the tremors, things like that. So they'll keep going. But I wanted you to know atropine is the antidote to organophosphate poisoning. I wanted you to know that there's something called the atropine challenge that you might have heard of. In certain clinical cases, the exposure might be very unclear. They might present like an organophosphate poisoning. And due to the circumstances and the severity of it, clinicians might use atropine as like an atropine challenge, where they'll give 2 milligrams of atropine, watch for if the worker has any certain symptoms. If the worker has certain symptoms, such as their pupils dilate quickly, they get really dry, hot skin, things like that, that might be indicative that they weren't exposed. So we use atropine to sort of challenge and test the diagnosis if there was an organophosphate poisoning in certain situations as well. But that's all I really wanted you to know about atropine. It's then titrated based on the severity of the poisoning and continually used in certain situations. So just remember, atropine, antidote to organophosphate poisoning. Next slide, please. The other treatment you might have heard of in organophosphate poisoning is 2-PAM. So I think we're going to give the resource of this report at the end of the talk. 2-PAM is essentially just atropine and pralidoxime. So you might see emergency medical responders come out and they have a thing that looks like an EpiPen. And this is just 2-PAM. And essentially the recent reports show that for organophosphate poisoning, 2-PAM has been used in certain situations, and specifically for carbamate poisoning. This report says that we don't need to use 2-PAM anymore, and atropine alone is usually effective. So just to know, there's the two options and a bit more about it, but we'll give the resource at the end of this talk as well. Next slide, please. So I wanted to talk about a bit about subacute exposure, because these are the patients we typically see in worker clinics. So I want to give you a quick example case. So this was a farm worker who presented with a several-week history of very vague symptoms. So he had headaches, dizziness, weakness, anorexia, and he said he was exposed to insecticides 3 weeks ago. We had no baseline testing on this worker and no other information. We took a thorough history, did an occupational history, did an examination, and then we got a red cell cholinesterase test, and the test came back at 10. And the normal range for this test is 18 to 8. And just to give those that don't know much about this test, so like I said, we're looking at, with organophosphate poisoning, obviously we can't test the acetylcholine or the cholinesterase levels in the nerve cell. So we use a proxy for it essentially and look at the cholinesterase levels in the red blood cells. There's a wide range of normal for this test, and it kind of gives us an indication about organophosphate poisoning. And it's very helpful if we know what the baseline level for the worker is. But in most cases, we're not going to know what the baseline level is. So this person's was 10, and the normal range is 18 to 8. Next slide, please. So it kind of poses the question then, because of this test, does this rule out organophosphate poisoning in this worker? And my kind of answer and the point to all of this is that no, it doesn't. Next slide, please. So the retest of this worker actually went back up to 17. So you can see it was much higher than 10. So he probably had a normal baseline level of sort of 17, 18, and it's reduced significantly, but it's still in the normal range. So I wanted to use this case as kind of an example that there's no perfect test to organophosphate poisoning in the clinic for these subacute cases. We use cholinesterase tests, both for the red blood cell cholinesterase and then the serum cholinesterase as sort of proxies. Most of the time, we don't have baseline testing. So you really have to monitor these workers and treat the worker in front of you and not just the test is sort of the lesson of this. The red blood cell, it's just a proxy for organophosphate poisoning. It's not going to be an acute marker, but it's a marker of sort of subacute exposure that we use as part of sort of the holistic management of the worker. So if you have a worker who's sort of lower range of normal, try and retest again and still keep an eye on them, even if it's within the normal limits. Next slide, please. And I say this because there's varying statistics, but I just wanted to share with you. If a worker has a 20 to 50% reduction in an individual's baseline cholinesterase level, this might mean they have excessive organophosphate exposure, but signs and symptoms may not appear until individuals' cholinesterase level has declined dramatically by about 80%. So there's going to be a lot of variability within your patients and your workers. And the second point I wanted to make is that there's genetic variation in people's susceptibility as well, and there are alleles for these cholinesterase tests. So about 4% of the population have an atypical gene for the serum cholinesterase test. So you have to be aware there's differences in the population that may make these tests look normal when actually the worker is being exposed to organophosphates. Next slide, please. And again, I don't want to spend too much on this slide because I think I've made my point, is that you might have a normal cholinesterase test and someone who presents like a cholinergic syndrome, like a poisoning, and it might be a true depression of a normally high cholinesterase level, like the case that I just showed you, or two, it might not be an organophosphate poisoning. Next slide, please. But I think that's enough about the treatment and sort of the testing of organophosphate poisoning to give you a good idea of how these tests are used. And now I just wanted to quickly talk about acute pyrethroid poisoning management. And there's not much to say here because unlike organophosphates, pyrethrins and pyrethroids, we don't have an antidote to. So it's very much supportive management. So we start with our ABCs and control the airway and the breathing and the circulation, like you saw they had to do for that child at the start of the talk. And then things we can do is decontamination of the skin and with soap and water, like this picture here. We don't typically sort of lavage, gastric lavage the patients because there's a high risk of aspiration pneumonia in these cases. So really, we don't do a lot. And in terms of testing, you can do some testing for metabolites, some GCMS testing, but the utility is really unclear and I've seen it very rarely done. So really, we just manage the patient and sort of go back to standards and basics of maintaining the airway and monitoring closely. And that's all we can do. Next slide, please. Lastly, I want to talk about rodenticide treatment. And rodenticides, again, like I said, is a very tricky class because it really depends on what rodenticide the worker ingested or was exposed to. But it also depends on the worker themselves. So we go back to principles again here about what's the susceptibility of the worker, what's their age, what was the intent of the exposure, was it accidental, was it intentional, how are they exposed, what was the dose, and what sort of rodenticide was it. If you remember that case at the start of the talk about the phosphide gas, obviously that's a really acute toxicant. But typically, in most instances, we won't see acute toxic doses of rodenticides like that they're exposed to. So it really depends on a number of factors here. Next slide, please. But if you want some easy principles about when to refer for rodenticide poisoning, I would say refer immediately if your worker or your patient has any signs of bleeding or bruising. If it was an intentional exposure, if they were exposed to a very high dose or ingested a very toxic dose greater than 1 milligram, or if they just ingested a dose and it's unknown how much, you can sometimes treat acutely within an hour with activated charcoal. So that can be another reason to refer immediately. Next slide, please. But sorry, let's wait for the slide to come up. But in saying that, about those key points about rodenticide referrals, I think it's important to make another couple of key points. And one of them is that I like to say is the absence of signs of symptoms or symptoms of bleeding doesn't exclude someone potentially taking a toxic ingestion. So don't just wait until someone has signs or symptoms of bleeding. The other point I wanted to make is there's often a delay in signs or symptoms after acute ingestion, and this delay can be up to 48 hours. This can impact labs we do, which may be normal after the time of ingestion. It might just be delayed, and symptoms as well. And the third point I wanted to make here was the duration of the anticoagulant after the overdose can be prolonged for several months. So what I mean by that is that these workers and these people exposed to certain anticoagulants can have symptoms for several months. And I think this is really important for patient education here as well, is that they may experience symptoms, they may have effects for several months, and we need to follow them up closely and ensure they're doing okay and ensure they're aware of what these symptoms might be so that they come back and see us for an extended period of time. Next slide, please. Particularly anticoagulants, I think they're such a common drug that we prescribe now, and people don't give them the attention they need. But when you look at data like this, so this is hospital data from Illinois, and you look at the case fatality rate of drug or sort of exposures in patients, you can see the case fatality rate for anticoagulants is nearly 4 times higher than any other class. So it's very high. And I think a big part of this is what I just said, is that we don't typically follow these patients close enough or for long enough, or stress the importance of them of presenting when symptoms and certain things do occur. These workers exposed to rodenticides do need close follow-up in some circumstances, and I think it's really important to push that and give it the attention it deserves. Next slide, please. I've talked a lot about different pesticides today, but I just wanted to go back and just take a step back just to basic principles for this slide and just talk about the clinical flags that were used to look at patients holistically. Because I think this is really important, and this is something that I've sort of had to teach myself as a clinician over the years, is that too many times do we focus on the pathology or the red flags for these chemical exposures, including pesticides. We treat the pathology instead of treating the patient holistically. And I think it's really important to consider that exposure to pesticides and exposure to any other work hazards is a very traumatic experience for many workers. It's something that could potentially kill them. It's something that's very scary for them. And you have to consider this and consider examining their mental health during and after the incident with a few questions. Check in how they're doing. Also look into their blue and black flags. So essentially, how has their job status been impacted by this exposure? Do they have insurance? Has their job changed? Are they still being exposed? Are they frightened about their job now? There's lots of questions you need to ask to sort of elucidate some findings in these different areas. And I think this is almost just as important as the pesticide exposure itself, because we can treat the pesticide exposure, but the trauma can stay for many, many years if we don't address it at the right time. Next slide, please.
Hey, Dr. Brett, just wanted to give you a time check that we have 9 minutes left, so I want to make sure we have time for Q&A.
Perfect, thank you. 3 slides. We'll do 3 slides in 3 minutes, hopefully. We just wanted to give 1 slide on the Poison Center. Please, if you don't have the number, take it down, 1-800-222-1222. Poison Center is a great resource. Please keep this number on hand. Reach out for advice when you have acute exposure situations. Multiple studies we've done have shown that the Poison Center's free advice has saved hundreds of dollars per poisons presentation to hospitals. They're a great resource. They can help you triage these situations. And like I said, pesticides is a very tricky poison to discuss because there's so many different types of pesticides. And this resource can be very helpful in giving you information about specific pesticides you're dealing with. Next slide, please. The last of our learning objectives for today was about some of the chronic effects. And this is kind of a growing area, the chronic effects of poisoning with pesticides. And I'm just going to share some of the information. More studies are coming out every year. So we're learning more and more as time goes on. But I just wanted to start with this case. So in terms of subacute effects of organophosphate poisoning, you might see instances where several weeks after organophosphate poisoning, you'll get workers or patients come in with sensory disorders. So this is a patient who had numbness and a peripheral neuropathy in their hands. So you can see the back of their hands in this picture. You can see the interosseous muscles. So they've actually got atrophy and wasting of the hands there. And this can be persistent as well for a very long time. So it's just something to think about with your workers that are exposed to pesticides. Ask the question if they've had any peripheral neuropathy, if they had any numbness, tingling, paralysis, wasting, things like that, and just check in because this can commonly occur as well in certain organophosphate poisoning. Next slide, please. So that's kind of subacute effects. And then now let's quickly talk about chronic effects of chronic exposure to pesticides. So like I said, this is new information. It's evolving every year. And it's evolving because we're starting to learn the mechanisms a bit more, because these pesticides can lead to a lot of different neurobiological mechanisms. They can actually deplete your levels of serotonin. They can permanently inhibit your cholinesterase levels. They interfere with a lot of enzymes. So this in turn causes a lot of damage particularly to our peripheral nervous system and to our brain. In terms of children, obviously children are a vulnerable population for pesticides. And this is really worrying. A lot of the research has come out, has shown neurodevelopmental delays from exposure to the fetus in pregnant women, as well as exposures to children at young ages. There's also an increasing body of research that shows exposure to pesticides is associated with attention deficit hyperactive disorder, or ADHD, and autism spectrum disorder. So this research is evolving as well, but it appears that there's a relationship there. In regards to adults, there's actually now a chronic diagnosis in adults, and it's known as chronic organophosphate-induced neuropsychiatric disorder, or it's got an acronym as well, OPI-NP, I think. And this is a syndrome essentially related to chronic organophosphate pesticides, and it includes things like mood instability, suicidal thinking, and cognitive impairment. That's all I'll say about it. And there's also studies associating pesticide exposure to Parkinson's disease. And then lastly, in terms of cancer, I'll just say the strongest evidence has been an association with acute lymphoblastic leukemia and maternal or paternal pesticide exposure. And similarly, in adults, we've seen chronic exposure associated with leukemia and non-Hodgkin's. And the last thing I'll probably say for chronic effects is there's a growing body of research about endocrine disruption effects of pesticides. And this includes sort of associations with female fertility, prostate cancer, semen quality, breast cancer, thyroid function. And this is an evolving area as well that continually bringing out new research about endocrine disruption that we should keep an eye on. Next slide, please. And I think, I'm sorry if that was a bit rushed. I just want to try and get through, and I hope it was informative today. I think it's such a big topic to talk about. And like we said, this is the start of a 3-part series, and we're going to share some resources in the chat, I believe, some of the resources I discussed today. And we're going to hopefully have a little bit of time for question and answer as well.
I'm not seeing any, let's say there's a Q&A coming in and the Q&A thing. Can you talk about the relationship to Parkinson's disease and pesticide poisonings?
This is a new body of research I do not know too much about, to be honest. I hadn't seen it in Australia. It was in some United States documents, and the EPA actually mentions it as well, I believe. But I think it is such a difficult area of research to determine causation, because obviously there's so many confounders in these groups, and it's very difficult. So they've deemed it an association. And I think it's just one of those areas to watch if they can get any more information on the actual mechanism of that causal link. But all I would say now is that there's a body of research that shows there's an association, and that's about as limited as the findings are right now.
Great. Folks are saying what an informative talk, but I'm not seeing any more questions come in. Can we go to the next slide? So just wanted to make sure that folks know that this is a 3-part series, and we look forward to seeing you at November 7th for our second session, and also on December 5th. So please join us. And you're going to see, do I hand it back over to you, Martha, to talk about evaluations?
Sure, Amy, let's go on to the next slide. Just a reminder that your evaluations are extremely important to us. We use them to basically make our webinars better and more informative for you. So do take some time to fill out the evaluation. Again, if you're going to request any type of continuing education certificate, nursing or medical, you are required to submit the evaluation. And also, if you would like a certificate of completion, you're also required to submit the evaluation. So go ahead and let's scan that on your phone if you'd like to go ahead and complete the evaluation now. While you're doing that, I'm just going to go ahead and close it off. I just want to extend my appreciation to
Martha, hold on 1 second. Just before you close it out, let folks know that the links are in the chat as well. If you don't want to scan it on your phone, you can just go right from your computer.
Oh yes, the links are in the chat. Sorry, me.
Yeah, and then the last thing I do, like, so we are sending a pretty comprehensive list of resources that will come with the slides and with the another chance to evaluate it. And the resources are for this presentation as well as for the next 2 presentations that we're going to be doing in November and December.
Thank you, Amy. So I'm going to go ahead and close it off now. I'd like to extend my appreciation to everyone who was able to join us today for this session, particularly Dr. Brett Shannon. Amy, thank you. And our wonderful interpreters, Susana and Azucena, thank you so much for your interpretation. A quick reminder to keep an eye out for a follow-up email that I'm going to be sending later this afternoon. In it, you're going to receive the link to MCN's website, where you can download the recordings, evaluations, PDFs of the PowerPoint presentations, any of the resources shared today, including additional resources that we think you will find useful. And all this you're going to get in both English and Spanish. So again, thank you, Dr. Shannon. Thank you, Amy. Thank you to the interpreter. I hope everyone has a great rest of your day. We'll see you next time.